Ladies and gentlemen, welcome on this session that is dedicated to quality indicator construction and feedback, the use of data to support quality improvement in hospital care. It's a Dutch-English cooperation between Imperial College London and IQ Healthcare in the Netherlands. I want to give a broad overview of... Oh, it reacts slower than I thought it would. I'll give an overview of the program. I will introduce the program and do a little bit of a speed date together with you. Rosella Hermens, she's the one on the left over there, will tell you something about the development of quality indicators. Renz, who is sitting right to her, will tell you something about the use of quality indicators in effective feedback systems. And Jonathan Benn on the right will give you an example and lead you through the whole process of quality indicator construction and giving effective feedback. Just to start with, perhaps could you raise your hand if you're actually involved in working with quality indicators? So, from experience, I think half to two-thirds of the audience has experience in working with quality indicators. So please ask questions, give feedback. We'll try to be as interactive as possible while working on this subject. The first thing with speed dating is that you find somebody next to you to date with and to discuss two questions with him or her. First, tell him or her a little bit about your experiences in the development process of quality indicators. And do you really use them in daily practice? Do you use them in constructing an effective improvement program? And how do you deal with that? I'll give you 2 or 3 minutes to discuss that. And then I'll ask some of people of the audience to give us some of their thoughts or some of their experiences. Start the speed date, please. If you're sitting alone, you can also talk to somebody behind you or...
Debbie will tell you because she ran it. Yeah, well, between us.
Could I ask you in a few minutes? Yes? Well, to answer to give you. Yeah? Well, I think we should stop the dating. The speed is over. And I'm going to ask some people to give some comments on the questions that we asked. Do you want to? Please tell them who you are.
My name's Debbie Janaway. I'm from England. We ran a project testing the use of weight-sensitive alarm systems on elderly care wards to see if they reduce the incidence of falls. And our very, very basic method of measuring that initially was by plotting the dot daily to indicate the number of falls, and that was something that we ran for about 3 months, so the wards could see each day and each week and each month whether there was a reduction in their incidence of falls.
And was it built into some kind of improvement system to reduce falls, or?
It was part of a care bundle, so we had an intervention ward and 2 control wards, and what we found in the long run was that you needed a range of interventions to reduce falls, not just a single one. And we now measure the incidence of falls using electronic systems.
Okay, can you please tell us a little bit about your experiences?
Okay, it's Mike Davidge representing Wales this afternoon. And we had a very interesting little discussion here about how you actually measure some of the things we really want to measure. So particularly measures of outcome, so patient outcome. And we want to do that, but it can be quite difficult to actually agree on what we're actually measuring. So I'll leave it there because there's probably other people who want to talk.
You want to say something? What you have discussed?
Well, we are a little late, but we generally discussed the value of indicators. My colleague...
Could you introduce yourself?
Yes, we are from Croatia.
From Croatia.
Yes. And we have some experience with PET project from WHO.
And what type of indicator are you using?
Well, we use 10 indicators.
This is a performance indicator for hospital improvement.
Okay.
So we started last year, and we have 25 hospitals involved, but it's on a voluntary based.
Voluntary based?
Yes.
And you don't have problems with getting your numbers right, with the registration of all kind of baseline measures, or is that no problem?
This is very enthusiastic, and this is on individual level. So each hospital, actually head of hospital nominated the coordinator for this task, and we developed Excel sheet because our hospital, the majority of Croatian hospitals, don't have information system. So it's manually collected data. It's time and human consuming. But we got some preliminary results to compare nation benchmarking.
And hospitals are compared with each other and they get a certain amount of payment out of it, or?
We just started to compare. We got first phase of results. So, and next month we have, each month we have workshops. But first of all, the main aim is to develop the culture of measurement.
Okay, thank you. I think we're now ready for the presentations. We had some examples from the audience. Rosella, can you tell us a little bit about the way that we should develop quality indicators in the right way?
Yes. Okay, I'm Rosella Hermens. I'm a senior researcher at the Scientific Institute for Quality of Healthcare in Nijmegen. And I want to tell you something about the development of valid and reliable quality indicators. Now, why should we focus on quality indicators? I think everybody knows that before you, when you want to improve patient care, you have to get insight into actual performance. And for this insight into actual performance, we have to use quality indicators. Now, what are quality indicators exactly? They are explicitly defined and measurable elements of practice performance for which there's evidence or consensus that they can be used to assess the quality of care and hence change the quality of care provided. Now, quality indicators can refer to the structure or the organization of healthcare. They can also refer to medical technical performances in care and also at outcomes of care. So there are different types of quality indicators. I think everybody knows that. And this figure gives an overview about the relationship between different types of quality indicators. As you can see, the patient enters the care process, and there he or she receives a diagnosis, a treatment, or follow-up. And these actions end in morbidity, mortality, or quality of life. And this care process is organized within a certain structure. And we have to realize that the outcomes of care are not only influenced by the care process, but also by the condition of the patient at the start of the treatment or diagnosis. In short, what do we measure with the different types of quality indicators? With structure indicators, you can measure to what extent certain facilities or structures are present in a hospital or a general practice. An example is the presence of a multidisciplinary consultation for cancer patients. With process indicators, it's possible to assess the quality of the process of care, for example, right treatment in accordance with the guideline. And an example of that is that the percentage of patients that received pre-operative antibiotics. And with outcome indicators, we can express the real result of the actual care. For example, the percentage of patients with post-operative wound infections. However, before you can develop valid and reliable quality indicators, you also have to think about your definition of good quality of care. And it's important to realize that there are different perceptions on what is good quality of care. And it depends on the perspective of the users and can be different for different users. For example, for authorities or the government, safety and accessibility of care are important aspects of the quality of care. And for care purchases, it's the payable care is most important. For patients, the patient-centeredness of care is very important. For caregivers, it's important to adhere to evidence-based guidelines. And for scientists, it's important to get insight into how an organization works and how it might be improved. So there are different perspectives and different definitions of good quality of care. Furthermore, we have to realize that different users can have different objectives to use the quality indicators. And in fact, there are three key roles of quality indicators. You can use them for understanding, to know how an organization works and how it might be improved. You can also use them for performance, to monitor if and how an organization is performing to an agreed standard. And you can also use them for accountability, so for in the transparency role. And it's essential to realize who is your user, who is the user of the quality indicators, and what's the objective to use them. And from practice, we know that in many cases this is unclear. Here you see this is an illustration of that. Many of you know the rankings of best hospitals in different magazines and journals. And in the Netherlands, Elsevier and the AD present such rankings yearly. And they both claim a ranking regarding the hospitals who give the best quality of care. However, when you compare the correlation between the both rankings, you can see that there's hardly a correlation. And the reason could be that they have a different perspective, but they both claim to use the patient perspective. There's something else, but we don't know exactly what. Now, which procedure do we have to use to develop quality indicators? First of all, from literature, we know that quality indicators have to fulfill different quality criteria. They have to be valid and reliable, they have to be acceptable for users, and they have to be sensitive to change. So, but the question is, how can we develop such indicators which those quality criteria? Now, what we know is that there are systematic and non-systematic methods to develop indicators. And non-systematic approaches often occur, for example, because certain data are available. And this can be very valuable in terms of assessing the quality of care, but little is known. You don't know exactly what the reliability and the validity is of these indicators. And when you use non-systematic approaches, it's also not so obvious what the evidence of the indicators is. And therefore, systematic approaches combining evidence and expert opinion are preferred, as they help to maximize the quality of the measurement. Now, examples of systematic consensus approaches are the RAND appropriateness method, the Delphi method, or the nominal group technique method. And these techniques are characterized by three aspects. The rating or judgments of experts are anonymous. The process is iterative with feedback. And individual responses are synthesized and aggregated into a group judgment. So before the measurement of performance, the following steps have to be taken. First of all, you have to assess the users and the goals of your measurement. Then you have to select possible recommendations or quality indicators. Then you have to reach consensus among the users about the key recommendations or the key indicators to measure the quality of care. Then you have to perform a practice test to test the quality indicators. And at last you have to give feedback on the performances. And within a few minutes, Anna will tell you more about feedback. For systematic methodology, there also we need some requirements. First of all, we need sources for indicators. Possible sources are evidence-based guideline or literature. And when there's not so much evidence, you can interview professionals or patients to get some subjects for indicators. Furthermore, review criteria for the expert panel are necessary, and the review criteria depends on your goal. It's possible to use the health profit as a criterion, or efficiency of care, or the patient-centeredness. Furthermore, you need reviewers to select the quality indicators. It depends on your goal, which reviewers you will choose. You can choose professionals, patients, and most of the time 10 to 15 people is enough. Then you need a review procedure. This can be written or face-to-face or a combination of both. And last but not least, you have to agree about consensus rules. Now, by testing and refining feasibility of systematic consensus methods in many IQ healthcare projects, we succeeded in the development of a practical systematic method to develop quality indicators for hospital care. And we've called it a RAND-modified Delphi method, and it includes the following steps. The first step is extraction of recommendations from evidence-based guidelines, literature, and if necessary from interviews. Then you have to translate these recommendations into a questionnaire. The next step is selection of key recommendations by an expert panel based on review criteria. Most of the time we need 2 rounds for consensus. The first round written and the second round a face-to-face meeting. After that, you have a set of key recommendations which you can translate into a set of quality indicators. And at last you have to do a practice test to test the indicators. You can find more information about the procedure in the following articles of our department. And in summary, the central issue in the development of valid and reliable quality indicators is to assess users and goals and to use a systematic consensus method. And at last, we have to realize that it's not measurement per se, but the improvement that is most important. Okay, I'll give the floor to Anne.
Well, thank you, and I will take over.
Thank you very much. Well, that last slide leads nicely into my presentation, but first of all, I'm Anna Renz. I'm a research psychologist at the Imperial Center for Patient Safety and Service Quality. And today I'd like to present to you a brief overview of 2 research projects I've carried out with the aim of understanding the role of performance data in quality improvement. So the overall aim was to understand how exactly do data lead to quality improvement, how do healthcare providers use these type of data, and what are the barriers and drivers to using data for quality improvement purposes. So I'm not concentrating on one specific system or type of data, but rather the aim was to understand what are the generic barriers and drivers to using data in acute healthcare settings. So the first project was a realist review with the aim titled The Impact of Performance Data on Quality of Care Outcomes and Provider Behaviour, and the search strategy located a total of 32 articles, and I included qualitative and quantitative research for this review to understand both the context and the situations in which performance data are an effective method for improving quality of care outcomes. And just in terms of the relationship between data and care outcomes, there were several mechanisms that were tested in the literature. They were the roles of providers, patients, and commissioners, and out of all of these groups, healthcare providers do seem to be the most responsive to data. However, even this relationship is inconsistent. And I was addressing further why the reasons for this inconsistency. And first of all, there seems to be a real preference for internal data. So healthcare providers seem to have a preference for internal data when it comes to continuous quality improvement. And there might be some misunderstandings about the terminology, since all of the data are collected internally, of course, but internal data were those data that were collated and analysed within the organisation. So usually this is not like the publicly reported data that we have for this sort of hospital ranking, but data that are somehow processed within the organisation. Now, the reasons for this might be explained by the other key finding, which is that the perceptions healthcare providers hold about performance data greatly impact on whether or not these data are used for quality improvement purposes. And two key perceptions are the perceived ease of access to the data and the perceived usefulness. And perceived ease of access is influenced by the dissemination intensity, and the more intensely or actively data are presented to healthcare providers, the more likely they are to be used. Another barrier is the complexity of data provision, and especially the qualitative articles in the review often included comments from healthcare providers who said that data were presented to them in such a complex way that it took a lot of effort to understand what it was trying to tell them. Another problem was the analytical ability of data users, which led to problems in accessing data. So analytical ability is a real barrier driver depending on where you are. One way to overcome a lack of analytical ability is to have a data mediator placed within a group or service that is able to support the healthcare provider in not just locating the data, but also interpreting and analysing it. Another driver was also having a central point of access. So in instances where this was available, the data was perceived as easily accessible and was more likely to be used. Then in terms of perceived usefulness of data, the level of analysis is an important issue, and that should really match the level of application. So if we're thinking of a data set that's applied at the service level, it should be analysed at the service level. And I think that's another reason why there's this preference for internal data, because external data is often analysed at the organisational level and therefore not useful for service level quality management. Then another big issue is the perceived quality and credibility of data, and a lot of data was perceived as having low credibility and quality, and therefore healthcare providers rejected it and didn't use it for quality management purposes. And then data timeliness refers to the time between data collection and feedback, and the shorter this time span is, the more attractive data are to be used for quality improvement. And there was lots of issues about data being fed back, sometimes up to a year after they were being collected, which then obviously describes a whole different type of settings, because people would have left and there was a new makeup of staff and interventions would have been carried out. So they felt it wasn't describing their service at the time and therefore was redundant as a management tool. But the problem with this review was that a lot of the articles were carried out in the US and largely concentrated on publicly reported data. So for my next project, I carried out a qualitative audit in a large London NHS hospital trust, for which I interviewed 22 staff within the organisation. And I started with the chief executive, but also interviewed people with specific roles for information management, quality management, and consultants, mid-level managers, senior managers, and frontline clinical staff. And the key findings were that there were two types of data used within the organisation. At the top level, it was really just used for external reporting, and it was very structured, and the data was used to gain a high-level overview of the individual services and divisions. But the real improvement, or the areas where data were used for improvement, was really the local or micro level, where, and at that level, the use of data or what kind of data the services used were largely autonomous in that. And there was a lot of variation within this one organisation in terms of the type of data they used or collected. So I started concentrating really on what are the barriers and drivers at this level that can lead to the use of data. Now, in terms of the organisational context, the real driver in this organisation was actually grace and favour, and because the use of data wasn't systematically integrated into the quality improvement framework, a lot of data use depended on people's goodwill and putting in some extra time in using data and trying to find data and collecting data. Another real driving factor, as the review pointed out already, was the availability of local data support. And there was one service which really stood out in the way they were using data, and that was the only service that had a person within their service who was able to analyze data and had the necessary statistical and analytical ability to make sense of the data that was collected in this service and analyze it for the group and feed it back and already make sense of it for the rest of the team. And again, an improvement in learning culture was a real driver. In instances where data was seen as a useful learning tool, it was more likely to be used than in other areas where it was seen as a bureaucratic exercise. And clearly defined roles and responsibilities were a big driver. There were lots of instances where people were really unclear about who was meant to do what, and unsurprisingly in those groups data was not used for improvement purposes. And another thing that was described a lot in the group with the exceptional data use was the role of their leader, who they felt had a very inspirational qualities to them and was able to develop some enthusiasm in this group for using data and to constantly set the higher goals for them in terms of achieving quality improvement. Now, in terms of barriers, the lack of analytical skills was something that came up in almost all groups, that especially those who were mostly meant to use the data, the managers of the services and units, felt that they weren't sufficiently statistically equipped. And they often felt it wasn't really the way they viewed themselves in their roles. So they said they have often had dual roles, clinical roles, management roles, and they said, it's not really my job to analyze data. I'm not a data analyst, I'm a manager. And so the problem of having these skills led to a lot of data not being used. Then something specific to this trust probably was a struggling information service, whose role really it was to support the individual services in their data use. But because the trust had recently merged 2 years prior to this study, there was a lot of staff shortages, and the information service was struggling in fulfilling their role in terms of the data support and concentrated really on providing the data for external reporting purposes. And there were other disruptions through the merger, like staff leaving and with that organisational memory leaving and lots of temping staff available, which didn't lead to using data. And like I mentioned earlier on, there was a lack of a central strategy or direction in terms of the use of data, which led to the very fragmented approach within the individual services. Now, in terms of data barriers, there were lots of cases in which people discussed the poor quality of available data, or in some instances even people didn't have any data available. And another problem was that in some clinical areas there wasn't any quality indicators that were published by, usually it would have been a professional body within this area, and some clinicians were talking to me and said in their clinical specialty especially they were having real problems of finding out how to measure quality, which also led to a lack of benchmarks and kind of goal setting. Then another problem was the lack of electronic data. These were cases where a lot of data had been collected at some point, but had been left in paper format because nobody was responsible for entering the data into a system, which would then allow people to analyze and interrogate the data. Which meant that especially managers often had to spend a lot of time on going back to the paper notes and trawling through that, which is obvious to see why that would put anyone off in using data. Then the lack of central platform was also discussed, as similar as in the review. And there were some staff who reported that they had access to a central intranet in their previous organisation, and they felt that that was a real driver to using data. So not having to go through so many different sources of data, but having one point of access at which you can access all the different types of data you would need. And having different data from different systems was again a problem following the merger. Following the merger, the trust still operated on two main patient administration systems. And from the system, people got different types of data. So even within one service, people might be operating on two different types of systems with two different types of data. So they felt they couldn't really compare even the performance within their own service. Then another interesting thing was that people always mentioned data is not equal information. And when I started the project, I was looking obviously at the use of data, and then it became clear that it's not really data that's being used, it's information, and before it becomes information, it needs to be turned into something meaningful. So there might be lots of data, but unless it's being analysed, interpreted, made sense of, and presented in a way that's meaningful and useful, data is not being used. And some people were discussing also that they were suffering from a sheer data overload, and they were being sent large amounts of spreadsheets and reports every day without any attachment of how this type of information and these reports were relevant to them. So they had to trawl through it and see, is any of this relevant for me? But since they were operating in severe time constraints, they didn't have the time to go through all of this information. So that was a problem with unfiltered data or information. So in order to make information useful and meaningful, I was asking all the respondents in this study, how would you like to have the data presented to you? What would be the most useful way for you to get the data? And there was a real thing about immediacy. And so if you're working in a time-constrained environment, they wanted something, especially the managers wanted to have something that's immediately telling them where they're at. Am I doing okay? Are there any problems? So they wanted something that's a high-level statistical summary, but then have that supported with some raw data as well. And the raw data would then allow them, if there was a problem anywhere, to delve into the problem, do some further analysis and look at it in a bit more detail. And also having the raw data allowed them to check for the quality of the data that was used for the statistical analyses. They also had a real preference for graphs and color codings, an alert system, which is again something that would quickly flag up. So have a nice visual graph with color coding, again saying, here, there's some problems in red, this is okay in green. And again, they didn't want too much data, so not being showered in too much data that they had to go through. Then one thing that they all mentioned was the usefulness of dashboards. So that's having one point of access where they can come in the morning, wiggle their mouse, and they can interrogate all the data that they would need for the day. Also, another important factor is having the data regularly and on a scheduled approach, or having scheduled feedback. And a useful platform for that seemed to be meetings. So in those services where they were using data continuously and systematically, they had monthly management meetings at which they had the overview of the last month's performance. And that seemed to work really well because it allowed them also to then go through the problems together and discuss any sort of improvement initiatives there and then. And lastly, the unit of comparison relates to really providing some context for the data. And they needed something that was a meaningful comparison. And interestingly, no one accepted the same clinical service from another organization because the organization was always seen as very different. So what they wanted was something, a comparison to someone that they would feel would operate in the same situation. So in the service where they did use data systematically, they were split into 11 different units. So every month they would see the performance of their unit against the other units, which they were accepting as a meaningful comparison because obviously it was within the same organization and the same clinical area, and they were then able to take on board that if they were performing worse than one of the other units, it must have to do something with what they've done. Then another useful thing is having comparison to standards, and like I mentioned earlier on, not in all clinical specialties, these are quite well developed. And temporal comparison refers obviously to assessing our own performance to the way we've performed the months before or the year before. Now, to summarize, to improve data use, I think the key factor that I've found through both of the research projects is to have local data support. And I think that's something with fairly little resources, it would lead to a lot of data being used because it would cut out all the barriers really that come up in both of the research projects. Then also having clearly defined roles and responsibilities, not just in who's using data, but also who's collecting it, who's entering it into a system, who's analysing it and submitting it. And then improving data presentation, and we should really aim at real-time feedback, but that has to be meaningful for the type of data. So obviously there's some types of data which have to be fed back more quickly than others. For example, if we're thinking about mortality data, it's not meaningful to see that on a daily basis, whereas some waiting times data is. Then provide raw data and aggregates. and concentrate on internal systems. So try and move away from data that's publicly reported somewhere at the organizational level, but concentrate on data that are clinically meaningful to the microsystems. And also aim to provide a central data platform and match the level of analysis to the level of application. And lastly, integrate the data use into a quality assurance or improvement framework. So really make sure that not just reporting data, but also the use of data is actively integrated somewhere. Thank you very much.
Right, well, thank you very much, Hannah and Rosella. We were now going to move on to a more practical part of the session, and we had intended to run a workshop around designing quality monitoring and feedback systems in which you'd be able to apply some of the concepts that you've heard about today to your own context of use. It became apparent to us, though, when we realised that we would be in this large auditorium, that it wasn't really set up for interactive group work. So we had a rethink, and what we shall do with the remaining 10 minutes or so, and leaving some time for questions afterwards, is I shall run through the a process that we were going to go through, but use a specific example from some work that we've been involved with back in the UK, in development of a quality monitoring and feedback system for anaesthetic care. So bear with me. We've put these slides together rather at the last minute for this, but I shall take you through these examples. So when we're thinking about, the focus is very much on how we actually use information effectively. We've heard about how we can define effective quality indicators, but that's half the process. The question is, how do we use the data that we get from quality indicators to support improvement in care? There isn't a great deal on this in the literature. There have been some systematic reviews of studies. You can see there's some outlined here. The study by Van der Veer, for example, was a systematic review of how medical registries provide feedback to healthcare providers. And there's been another recent study by De Vos looking at the effectiveness of use of quality indicators to improve hospital care. These studies conclude, along with others looking at the role of knowledge of results, that feedback can be effective in improving quality, but when it's combined with other methods, and indeed it's very difficult to actually evaluate feedback systems, essentially information systems, as quality improvement interventions, due to their heterogeneity, due to the fact that they vary between local contexts of use, and due to the fact that they're normally introduced as a component of a broader, more complex intervention. There have been a number of case studies and qualitative studies looking at this area, and qualitative research suggests that effective data feedback has a number of characteristics, and indeed Anna's touched upon these in her own work. But elements such as timeliness, specificity to the local context, origination from credible or respected sources, non-punitive use, and data that is sustained over time. So as I said, we were going to run a practical exercise, and it was going to look like this in terms of actually going through the stages that one might go through to actually consider the key design requirements for effective data feedback systems. So this is a 7-step process that we were going to break them into 4 stages. I shall just run through some of the main points from here. So in terms of defining the overall function and the focus and scope of a quality monitoring and feedback system, Rosella's outlined very nicely a process for actually identifying quality indicators and defining quality indicators based upon the principles of user involvement, expert consensus, and incorporating evidence base. I think it's important to define the overall function of the system. What is the aim in introducing the system, particularly in terms of what unit or level of analysis you're looking at, to identify and engage end users and key stakeholders from an early stage, and also define the data use policies that will eventually be used in terms of how the data is used within the organisation or for whatever purpose. So obviously once those overarching questions have been decided, you can move on to the specifics of deciding upon what metrics you will actually collect, and the actual operational definition of those metrics in terms of frequency of measurement and sampling and the data collection mechanisms. In terms of defining the overall function of the system, this type of framework is useful. You'll no doubt have seen this before. This is a slide that IHI uses quite a bit in terms of the differences between measurement for improvement, measurement for accountability, and measurement for research. And depending upon the purpose of the system, that will affect its definition and the requirements in terms of feeding back at different levels. So in anaesthesia, for example, the aim was to use routine data feedback to support the continuous quality improvement process in anaesthetic services. The primary aims was to provide feedback on compliance with standard perioperative guidance to individual clinicians, but also to provide feedback on quality of anaesthetic care and the productivity aspect, perioperative workflow, to the local anaesthetic department. So we have two levels of analysis there. We have a level of analysis at the level of the individual clinician, but also at the anaesthetic department. And in terms of data use policy, it was set up to be anonymous, so de-identified data at the individual level, and separate from the formal appraisal process, so again, non-punitive. Our definition of the quality indicators that we used were that we would look at various indicators of quality of anaesthetic care collected in the post-operative recovery unit. So temperature on arrival in recovery in accordance with NICE guidance, and patient-reported measures based upon research-validated scales, a standard quality of recovery score and patient-reported post-operative nausea and vomiting and pain. In terms of patient flow, we actually measured the delay in transfer from the post-operative recovery unit to the post-operative surgical wards, a metric which we called ward wait time. So in terms of having decided upon the general aim and scope of the system and what metrics will be included, we move on to think about what were the data analysis process and what are the technical implications. Now again, these will vary considerably from context to context, but it's useful to think about how one wants to analyse the data and actually present that data back at this stage to understand the technical requirements. So specifically, defining the frequency and the type of analysis that will be performed, for example, if it's periodic review, incremental monitoring, statistical process control, whatever type of analysis one will use, and to consider the trigger levels, the guidelines, the control limits, or the targets. For example, in anaesthetic care, we decided to use the statistical process control charts as a method of feeding back data. So we were actually looking at data longitudinally in time series in order to monitor variation over time. Again, a key issue in deciding at what level to monitor within the system is how one actually aggregates data. For example, a good example from the anaesthetics work, this is the ward wait time reported at hospital level. So this is variance in delays from transfers from post-operative recovery over time, actually at the hospital level. If we fed that back to the post-operative surgical wards, well, they wouldn't necessarily recognise their performance in there. If, on the other hand, we actually break it down by individual ward, and the scales of these graphs have actually been adjusted so that they're all the same, you can see that there's considerable variation between different surgical wards. Some are very nicely in control there in the bottom left. Others show high variability and trends towards actually getting worse. So thinking about the level of aggregation is very important when we're thinking about how to use data feedback. I'm going to skip forwards to the next stage, which is to actually plan the feedback process and the format. So again, we need to think about the frequency of feedback. Over what period does it make sense to provide knowledge of results? Obviously, if we're feeding back at the individual level, it's important that individuals can associate the data that they receive with the performance event itself, if learning is to occur. So the actual feedback schedule is important. Again, we need to think about the data presentation format, usually with some end-user involvement in the development process. And there are a number of different formats available in terms of summary statistics, time series charts, providing benchmark data. And I'm sure you're all familiar with reports or scorecards and dashboards. The mode of delivery or channel for feedback is also extremely important. So there are several different approaches, obviously, to presenting data. We can present cross-sectional benchmark comparisons, which are static in time, or we can look at variation over time. Again, in the anaesthetic context, we provided monthly individualised reports to the department, but also to individuals, and we provided feedback at the departmental level through those channels at the bottom there. Postings of departmental ward level data on bulletin boards in the post-operative recovery suite and the surgical wards, and regular presentation at departmental audit meetings. So this is an example of the types of different formats of data presentation that we use in feedback and the public postings within the clinical work areas. Finally, it's very important, of course, to consider how the feedback links to action mechanisms. And this is crucial if the data that we collect against quality indicators is going to be used effectively to actually make meaningful changes within the system. So in terms of the action mechanisms, we need to think about defining a process for use of data at different levels, identify key roles and responsibilities, and develop the accompanying guidance for how that data will actually be used. In terms of the anaesthetic work, for example, use of data was used at the individual level in the personal professional review and development process. But we also link the data to broader quality improvement activities through association with local programs and initiatives, and periodic review of departmental data at the joint audit meetings, so part of the local clinical governance process. That's a model of the whole system, as it were, but the important point is you can see the anaesthetic system there in the box at the bottom with a simple input process output model with patient flow through the system. The point is that when we collect data from that system, we actually close the loop. So we actually complete some formal analysis process, but that data is fed back and results in meaningful action to change the system. And I shall leave it there to give us a little bit of time for discussion. Thank you.
John, thank you. Are there people who want to pose a question, or just raise your hand and I'll come over? Some of your own experiences, or yeah. Please see your name.
Yes, my name is Ida and I'm from Denmark. I work at a regional level with the quality data, and I find that the biggest problem is not so much in development, but with the data barriers that you mentioned. How do we address the problems about the lack of data, especially in the quality area? Because we have lots of economy data and data on productivity, because that's been the main focus. And I often face the problem of having developed an indicator that I think is good, but it's not possible to carry it out.
Who's going to answer that question?
Did you want to talk to that?
What you just mentioned about the availability of financial data, that's something that I found as well, and that's something that's a lot more structured than quality data. And I think to have quality data available, the first point is collection, and for that I think it's important to have some ideas of what we want to measure, what's important to us in terms of quality in a setting, and then have clear roles and responsibilities, and make integrate into your daily work and make sure this data is collected. But there's a lot of organisational barriers and drivers that can impact on that.
Thank you. Hello, Friso Ramakis from the Haga Hospital in The Hague. I've got a question for Jonathan Benn. You said when you give the feedback to the ward about the quality numbers, you said you used tables and you used graphics, but last presentation we heard about using narratives for the frontline personnel. So doctors and nurses are not very familiar about the statistical knowledge. Is it better to use narratives instead of graphics?
That's a good point, and you're quite right. We have focused largely on quantitative data feedback. I'm sure there is a role for narratives in communicating with the front line. I would say, though, that the format in which we present the data up in the wards is very simple indeed. I mean, we are just talking about daily dots on a time series chart, and it is fairly straightforward for individuals to understand variance in level over time based on that, and we found that people can relate to that quite well. We don't try to push control charts, obviously, on the wards, but simple run charts actually work very well.
Other questions, remarks?
I'm making a move around.
Hello, Ross Patterson from Edinburgh in Scotland. How do you keep people interested in those run charts that are going up on the wall?
Sorry, could you repeat that?
I do the same. I've got run charts on the wall.
Yeah.
They can quite quickly become wallpaper. How do you keep that interest? How do you keep people excited about them?
Well, I guess the data feedback is part of a broader quality improvement work. So the data supports the quality improvement work. So we do have people that are working with the frontline staff as well to address issues such as communication around patient transfer and that kind of thing. I think pairing the data feedback with broader intervention strategies maintains the interest and is mutually reinforcing.
And they shouldn't be used as wallpaper, of course.
Yes, that's quite right. Thank you.
Okay. Another question. I think it should be the last question because we're running out of time.
Okay. Thank you very much. I'm Ibrahim from Uganda. Something slightly related to what he has just asked, but this is now at a national level. How do you work on data feedback to influence legislators? Because from the discussion it sounded like this is data used in the hospital, but there are situations when we want to influence and get support to have better care.
Did you hear that one?
Is there?
I'm sorry. Again, we didn't quite understand the question, I'm afraid. Sorry. Would you mind just clarifying?
The issue is that sometimes there are situations when health workers want support from national levels, and the data we use is intended to improve care, our processes, our outcomes. But there are situations when we feel like if we shared this data, then we would be able to influence the legislators, the politicians, who may not be with a medical background. And how do we work on it so that we improve to make them understand better and be able to support the healthcare system?
You're more talking about performance data that are used or misused by politicians or perhaps the press, or how to get them into a kind of improvement framework on a more systematic level. It's a difficult question. Yeah. We could have a second session for that. Or
it sounds like a very tricky problem indeed. I think when you're planning the systems that you will influence with the data, we need to take a multi-level approach. So we need to understand at what level that feedback loop actually operates. I think using data for local improvement work, it's incredibly important that the loop closes at the frontline level within the local system, but if you need to influence higher levels within the system, regulatory levels, then ensuring that your data processes link up and the loop is actually closed at that level is very important indeed.
Okay, John, thank you very much. Public, thank you. Speakers, thank you. Enjoy the weather, enjoy Amsterdam. Have a good evening.